I want to welcome everybody to the 6th Annual Advanced Care Planning Summit. We're very, very glad to have you join with us today for the next 90 minutes. We're going to do this in one batch because we know older adults can sit for 90 minutes without getting distracted, and so there will be no breaks. But we're excited to have a robust agenda to discuss this important topic. First of all, I'd like to thank our Advanced Care Planning Advisory Group. If you could move the slide to that, would appreciate it. To give you an idea of some of the individuals who our organization represented, individuals that help plan these summits every year and meet a few times a year to make sure that we keep this topic alive and do everything we can to spread education about advanced care planning. Another thing we just want to mention really quickly, if you go to the slide on the agenda. We had a slight change from what was originally put out there. Our keynote speaker yesterday had an emergency, an unfortunate death in the family that required her attention. We collectively send our concern and sympathies to April and her family for what they're experiencing right now and wish them the very, very best. Dr. Cami Collette has graciously agreed to slide into the keynote position and has expanded her topic a little bit. And she has been a pioneer on this issue in so many ways, as long as I've been involved with it. And we're thrilled to have her expanded presentation today. And after Cami's through, Dr. Collette, we're going to hear from Sherry Myers. Both of these individuals will be introduced by our colleague, Adrienne Butterwick, who has been such a critical collaborator and leader in this effort over the past several years. And then after Sherry's personal story, she will join an interdisciplinary community conversation with 3 other individuals that we'll introduce it later in the program to give us a feel for perspectives of advanced care planning as it shows up in social work, as it shows up in public policy, personal lives, as well as in intercultural and ecclesiastical settings. So we look forward to that conversation. Our objectives today, again, as always, is promoting the best practices for sharing advanced care planning concepts across the treatment continuum. Also to make sure that we all understand different steps that can be taken to prepare for emergencies as it relates to all stages of life, and to apply these strategies for inclusive approaches. It's great to have these conferences, but this group is literally the choir I realize we're preaching to. And so what our job is to inspire you and give you the proper tools that you will help disseminate this information amongst your clientele, amongst the patients you deal with, the individuals that you counsel with, and the counsel you give. It's all very, very critical, and we depend on you and all of us to make sure that we spread this to the communities so people are prepared for events in their lives, sometimes seen, sometimes unforeseen, and that they are making the decisions that honor what they would wish for themselves, and that we're all able to support that. So at this point, I'm going to just turn it over to my partner, Adrienne, for a few comments and the introduction of our keynote. Thank you.
Thank you, Rob, and welcome everyone. We are so pleased to have you here. It has been a little bit of time, given everything that's gone on over the past few years since we've come together. So we really appreciate you joining us and are glad to be back together today. So real quick, just a couple notes about using Zoom. Just want to make sure if you are able to please turn your camera on. This is set up as a meeting so we can see and exchange conversation with each other. So please, if you're able to have your camera on. And also, if you have any questions, that we will have some specific time dedicated to answering questions as they come. So if you have any questions during our dedicated space, please feel free to unmute. You can see here on your screen in the far left box, you will be able to mute and unmute yourself. If you're not speaking, please do mute yourself so that we can minimize any background noise. And this is also going to be recorded. So we would like to just minimize any of that background noise possible. Next slide, please. And then, as we mentioned, we do really want to welcome your questions and comments as throughout the presentation today. So as you have questions, please feel free to put them in the chat. As you can see on the screen, there's a chat button there. You're welcome to send chats individually. If you have questions that you would like to be asking anonymously, please feel free to send them directly to myself or Rob Entz. The two of us will be both moderating the chat. So if you have questions, you do not need to wait to put that into the chat. Go ahead and put it in, and we will address those as we go along. If there are any questions that we run out of time and are not able to answer today, we will be sure to answer those and follow up via email with the group. So please don't be shy. We want to hear all of your thoughts and comments as we go throughout our session today. Next slide, please. And just a few more logistics. As I said, this is being recorded. We will share this recording with all of you, and this will be available on the Utah Aging website as well as all of the other presentations and resources mentioned today. We have been approved for 1 nursing CEU and 1.5 social work ethics CEU. You do need to submit your information via the survey that will come via email after the summit today. So look for that. That's how you'll be able to collect your certificate. And as I said, please feel free to put your questions in chat as we go, or during the time we have dedicated to Q&A, please feel free to unmute and ask your questions. Next slide, please. And just a quick note that this group has been active for some years now, even given the pause during the pandemic. And we just want to say thank you to all of those who have really shaped where we are today and have contributed to our efforts over the years. So this is our larger group, and we just really appreciate the community and professional collaboration that allows us to collectively work together in this space. Next slide, please. And without further ado, I am very excited to introduce Dr. Camille Collette. She is just one of our favorite people here in the ACP space. I know I'm a little bit biased, but I just had to say that. But Dr. Collette was raised in Colorado. She came to Utah in 1975 to go to Westminster College. She attended the University of Utah Medical School from 1979 to 1983 and completed her family medicine specialty training at the University of Utah. She joined the faculty at the Department of Family Medicine in 1986 and then developed a new family medicine residency in the 1990s that is now based at St. Mark's Hospital. She has cared for patients here in Salt Lake City over 30 years and continues to see patients in the clinic and hospital setting. In 2016, she went back to Westminster College and completed her MPH, her Master's of Public Health, and completed that in May of 2018. She is on the National Provider Order of Life-Sustaining Treatment POLST Committee and the co-chair of the Utah POLST Registry Committee. She has conducted presentations on advanced care planning locally and nationally in order to help patients prepare for their care in times of medical emergencies. Without further ado, I would like to turn it over to Dr. Camille Collette. Thank you.
Thank you, Adrian, and thank you, Rob. I'm happy to be here. We can go on ahead to my slide. We're going to be talking about being mortal. There's a lot to talk about. Let's go ahead and go to the next slide. Each of us has our own story. I was raised in Colorado by my father, the doctor, my mother, the nurse. It was great until 1971 when my dad suddenly died of a heart attack. I was 14. My older brother was 16. 13-year-old brother was with my dad when he died. And then a 10-year-old brother, an 8-year-old brother, and my dear mom, 44, widowed with the 5 of us to raise. So we all have our own stories, how that death affected us and where our lives took us. Let's go ahead and go on to the next slide, because everyone has a different experience and we have come from different cultural backgrounds. And in some societies, we just we don't talk about death. It's actually something that some people fear that if we talk about bad things, they might happen, or we just believe that nothing bad will happen if we pray. We've got to have good miracles. And I even had patients when I was discussing the possibility of their family member dying. They said, well, we want another doctor who actually is going to believe that our family member won't die. So we have to understand that this is a very challenging thing for all cultures. Let's go to the next slide. So there's language differences. Who is the head of the household? Who do you talk through? And then, of course, there's different traditions for families. But I think that some of the most challenging is, believe it or not, the homeless and people who have no one to speak for themselves. But we're going to go on and go to the next slide. As we as medical providers are trying to share these really difficult situations, I think it's important that we understand the family and patients are coming from one set of knowledge base. And we physicians or medical providers, we have a whole different language. And we have to kind of build a foundation of knowing about the family and knowing where they're coming from and helping them to understand where the illness is. And we need to use language that they can understand in order to get to that magical shared decision-making. And this takes time. And sometimes the house is lopsided with little knowledge for the family, too much knowledge being spread for the patients, and you sit kittywampus. All right, let's go ahead and go to the next slide. Advance directives are one form that all adults over 18 need to help designate someone who could speak to us in case of emergency. I like to think of it as emergency preparedness rather than getting ready for death, because everyone might need someone to speak for them if they end up in a car accident, in a hospital, they're unable, coming down with COVID, being sick on a ventilator. We've been challenged in the last couple of years with dealing with who speaks for this patient. But a pulse form, that is something more at that someone might die, and the next year's more a serious illness that comes in a different form, but both take a real important role in this continuum. Let's go to the next slide. We have the pulsed form, of course, for the seriously ill. This is really something that medical providers do. We fill out. I'll go over exact forms. And the advanced directive is something really patients can do. They can do it with their lawyer. They can do it just among their loved ones. Different states have different roles for both of these forms. Next slide. So when thinking about advanced directives, there's the typical 5 Ds or Ds of the advanced directive. When do you need to change this? Every decade, you should at least review it if you're a young person with just over 18. But sometimes we've had a death, a spouse, or the ones that we have named have died, or a divorce. If we get a new diagnosis, or if our health suddenly declines. And then because every state has a different form, if you live part-time in one state, or your family members, you've just moved your parents into your state, but they used to live in another, you need to revisit and make sure the forms are updated and have the correct information. All right, next slide. Where do you find this information? Great website that's been developed here in Utah, utahaging.org. If you have not visited this site, it is amazing. If you click on the advanced directives section, you'll see the form. It is actually fillable. You can actually type your name, your address, and then you'll need to print the form in order to be able to sign it. Then the Pulse form is also available. We have it in Spanish as well. And then we have some slides that are there that are really actually quite wonderful. I guess I've been involved with it, developing with Rob and Troy Wilson, the first 3. And then the last one that's just going over how do you actually fill out a Pulse form properly. Let's go to the next slide. So here in Utah, we're actually pretty lucky. We've got a form. It's a 4-page form, but it does not need to be notarized. People can fill it out, but it is a little bit legalese. And I think that it takes a little bit of time to really understand what these pages mean. If you go to the next slide, I've just have the first 2 pages on. So the first page is really the heart of the advanced directive. Who are you? What is your date of birth? And then who are the 2 people that you trust to make the decisions when you are unable to make those decisions? The second page because it's a separate page, you do need to print your name at the bottom. And then there's little sections to sign. It's actually an initial on those yeses in area E. And F, you usually initial yes if you want those two people as your guardian. And then if you decide you want medical research or you don't, if you're an organ donor or you're not, and these require initials as well. Let's hit the next slide. So now we're to all these different options. And I mean, you can be overwhelmed by the which one do I choose? The important thing on this page 3 is you really just want to choose one off of this page. The first option says, hey, I've discussed it with my healthcare agents. They know, talk to them. You initial that, one and done. You can go to 2 and say, hey, I want everything done no matter what, just prolong my life. Option 3, hey, I want to have some limits put on. I don't even want, maybe you don't want antibiotics, you don't want IVs. Sometimes this gets a little bit too overwhelming. And I think that if you are not near death, it's important to maybe just discuss it with your family members or friends who you have designated as your healthcare proxy. I always find that option 4 is interesting, as I do not wish to express, which is kind of defeats the purpose, but you can initial that and then print the name. And on to the 4th page, basically you need to sign this form in front of a witness. As I explained to my patients when I'm discussing with them, they do not know, the witness does not need to know what's on the first 3 pages. All they need to do is witness the form being signed. The person has to be over 18. They can't be your caregiver. They can't be your doctor. They can't be your family members. They have to be someone who is not going to be affected by your death. A neighbor, someone in your church or ward. So this can be witnessed by anyone. All right, people are wondering what CPR. Let's go to the next slide. I always find it fascinating, TV. We have our impression of CPR is such a great intervention. And on TV, at least 77% of people survive. It's amazing, but that's unfortunately not what happens in real life. I do see a little question, by the way, back in the chat, who signs the PULSE form. The PULSE is actually signed by a physician assistant, or nurse practitioner, and the patient or the actual healthcare proxy. So I'll try to answer answers to the questions as they come up in the topics there. But back to CPR. I have found a wonderful slide that I think is great. Let's go to the next slide. This is actually in the PULSE conversation guide that I'll list at the end. And a study was done, granted back in 2013. Things have not changed all that much, but when CPR or cardiac arrest happens in a hospital setting for someone who is 65 and older. 65 and older in the hospital, their heart stops, they are not breathing. That is what this study studied. 49 die, they never get past the CPR. 34 died during the hospital and they never get discharged. Of the 17 that survive, about 7 die after hospital discharge, and the 10 that are alive, some of them have some disability. They may not have full capacity after the CPR. So as we get older, CPR is not as rosy as we think. It was really designed to help save a drowning 2-year-old, young people, people with good, healthy organs. And if you're at the end of your life with failing kidneys, failing heart, failing lungs, CPR sometimes is not a great option. But this is what we discuss in the PULSE form. Let's go to the next page. So now we're to the nitty-gritty. This is the actual PULSE form. This is for the state of Utah. Every state has a different form. There's actually a national form as well, but Utah prefers that we use this form, but they will recognize out-of-state forms if shown to the emergency medical in a time of a cardiac arrest or in that urgent time. They will recognize the national form. But each of these forms have the same important information. Who is this person? Their last name, their first name. When was this order done? The nice thing about the PULSed form is it is signed and it will last. It can go from the hospital to the care center to the home health. This is a form that goes over the continuum of care. You need to put in the date of birth. Last 4 digits of the Social Security is fine, but not everyone has a Social Security number. So as we have, refugees or immigrants that are not citizens, we have to be aware that this may not be one of the boxes that gets filled in. Their address is nice to have, but that can change as well. But it's nice to have a physical address and not really a PO box, because emergency medical people are going to be responding and they want to know who is this person at this address, or the patient carries this form on them. The important thing is, who is their current doctor? Because sometimes the EMS, they'll actually call the doctor. And so the phone number, and we have been called in the middle of the night with someone that for covering 24 hours. What is going on? This is happening to one of the patients. What information do we have? The next section, knowing what the patient has. What are the illnesses? Do they have diabetes, heart failure, kidney failure, history of seizures? These are important medical conditions. But the next box, I think, is the meat of the matter. This is stating, what's the goal? What do the patients want out of this? What makes life worth living? And if by going on dialysis, they'll be able to live long enough to see that granddaughter born or the grandson married, there are important things. What is the goal of all this care that we're doing? What gives this person, this individual person, joy? Now we'll go to the boxes of marking. So you can just mark, yeah, please do CPR, attempt CPR. But the purpose of this form is to say, hey, if my heart is stopped and I am not breathing, I do not want CPR. I want to allow a natural death. One of the things that we use, the DNR, some folks have argued maybe we should change that negative connotation of DNR to AND, allow a natural death. And of course, you actually could rest, I don't know what I want to select. If you say, I do not wish to express anything at this time, the default is everything will be done, including CPR. Then we're going to go on to the medical interventions. You can have an incredible full treatment. I want antibiotics. I do want everything. I want CPR. I want defibrillation versus limited intervention. I do want IVs. I want antibiotics, but I don't want CPR. If you mark that you do not want resuscitation, the box that the doctor and the patient or their proxy agrees on, that the limited interventions, if they're at the time of their life where time is short, comfort measures are the ideal. And that's usually the time when hospice is offered. And you can make no preference, but then the default is that everything is done. Let's go to the next slide, and it will bring in the question that's been put in the box, the chat box. How do you clarify the advanced directive plan and the PULSed complement? How do they complement each other? Because it seems, that they're different things, but the advanced directive is for anyone over 18. So when kids go off to college, it's probably a good idea in emergency preparedness to know, do they want mom, dad? Maybe their parents are gone. Maybe they were foster kids. Who is going to make decisions for this person if anything happens? So the advance directive is the main thing is saying, who do we call? And hopefully they know what your wishes are. In the section here, in the form, this bottom section that I'm showing you, you can choose if you want artificial feeding, a short term, a long term, no feeding tube at all, or not. I don't know what I want to express. The advance directive section, that is, well, did you have this advance directive in front of you? Were you looking at it? Who is their healthcare agent? And are you discussing it with the patient alone? Or are you discussing this with an entire family? And then the patient, if the patient is the one that you're discussing, they can mark the box. Over to the right, you see the patient want this order followed strictly. In fact, my mother in Colorado, she marked this box and she said, honey, I know you're a doctor, but I don't want you to be able to change my wishes. So she had a MOLST form in Denver, in Colorado, a medical order of life-sustaining treatment, but it was very similar to our PULST form that we have in Utah. Then we get the signature of the patient or their healthcare proxy, their spouse, their father, their mother, their uncle, their cousin, their brother. It's nice to know who is the one, or is it a friend that they have designated? And ideally, it is nice to have the advance directive that confirms that this person who is signing this form is the one who is actually the patient, who the patient wants. The physician, the next signature is the actual provider, and maybe there's someone helping to fill the form out. I usually fill, and I have signed both of these sections where I print my name, I put my license number. I may be the hospital doctor at the time when I'm filling this out, and I'm not their primary care provider. Or I could actually be their actual primary care provider, and I'm the one that maybe get called. We date the form. Now, COVID has brought in a whole new light because we have been doing conversations with people who could not either get on a plane and be there or couldn't come into the hospital room. So last year, and then if we flip to the next slide, we'll go to the slide that says that we updated this, that instead of an actual signature, we could get a verbal conversation and have two medical people hear and give the permission where the healthcare proxy is talking for the patient who is not able to speak. And we know that this is the healthcare proxy because we've called them directly or doing a FaceTime or however we're talking with them. And then we verify it. And the Utah State Legislature said this is all right, as well as electronic signatures. And some hospital settings have that. Some patients don't have the ability to do electronic settings and signatures. But this, Senator Johnny Yamamoto was wonderful at helping us get this passed back in 2021. Let's go on to the next slide. We've got a lot of resources. Now, there are commercial resources that are available out there, but these are mainly the .org resources, and well as the utahaging.org. That's where the Pulse Conversation Guide, which I'll show you what that looks like. Leadingwell.org, great website for the state of Utah. Pulse.org is the national Pulse provider order of life-sustaining treatment, physician order of life-sustaining treatment, or some use it as a medical order, but it all has it for whatever state that you are in, you can find your state's form. The Conversation Project is wonderful, has so many resources, as well as Prepare for Your Care with advanced directives. 5 Wishes is also, recently we've had that accepted as a approved advanced directive for the state of Utah versus the form. And the nice thing about 5 Wishes is a very simple document that's in plain English. All right, let's go to that next slide. We've got the Pulse Conversation Guide. This is a guide that it's wonderful, has resource. How do you have these conversations? How do you respond with empathetic answers? There's entire courses on this that I'll talk about, but this guide is available also on the utahaging.org site, as well as we've got it listed in many places. Comagine, they used to be Health Insight. They were the ones that also helped to get this original guide developed, and it's been updated since. Let's go to the next slide. So there are books to beat the band. You can do a Google search, 20 best books for children, 20 best books for adults in grieving. I have found these books to be eye-opening. Atul Gawande's Being Moral book. I read this so many times while my brother was dying of lymphoma. It was the hardest thing to lose a sibling, and for my mother to lose a child. At age 56, we did not expect my healthy young brother to die, but that book got me through. The other, there's Everything Happens for a Reason and Other Lies I've loved. This is a great book as well. She just recently came out with another book, which I find fascinating. The title is There's No Cure for Being Human. So onward to the next book is When Breath Becomes Air, a journey of a physician who actually was diagnosed with a severe illness, and how he and his wife faced that. And then Option B, where Sheryl Sandberg suddenly lost her husband. So let's go to the very next slide. So this is just, books are one thing, but then you can go to all the resources of how we train, how we talk. And Vital Talk is a great organization that has classes. You can become a trained speaker with Vital Talk. This is more national, but they've got an app for that. Yes. And so Vital Talk app, Vital Tips. And this is what I took pictures of my cell phone where I could refer to that. And then let's go to the next slide. UCOPE is a Utah training program. Amazing. I've actually attended this course 4 times in the last 12 years or so. I find it very helpful to practice. They give you, it's a 4-day course where you get to practice with that conversation. And then if you just go to the next slide, it gives a little detail of all the different things: communication skills, ethics in palliative care, dealing with grief, conflict resolution, and then cultural curiosity. And how do we physicians also care for ourselves? This is hard. And it's been very hard with COVID. Many people have felt the burnout. I'll just go on to the last slide. Of course, we've got National Healthcare Decisions Day coming up, April 16th, if you haven't heard. There's one thing we have to pay taxes, and death and taxes. So thus, the National Healthcare Decision Day is always April 16th. So I'm going to go back to answering some questions. There were some more questions in the chat. What we don't do is full code, limited interventions. Those are incongruent choices. This is something stated on the Pulse back of the form. So limited interventions, if you do want antibiotics, IV fluids, but you don't want to have CPR. So this is not a black and white. It's not it's something, and it can evolve. Some people can say, today I want to be full code, even though they may have signed a Pulse form. The Pulse form can easily be reversed for just a short period of time, depending on what is going on in a person's life. So I'm going to open it up to more questions. I hope I hit most of the ones in the chat box. I think Emmy was saying that there's going to be a movie that Atul Gawande's going to do. That's kind of exciting, on Being Mortal. So I'm opening up for questions. Adrian.
Cami,
Rob,
there was
yes.
a question, I believe, earlier from David Dyatt. I'm not sure it got answered, about once a Pulse agreement is signed, if the provider who signed it happens to die before the patient, does it cause any effect on the Pulse agreement, or does it hold as long as it was valid at the time it was signed?
And that's a great question. If the provider was alive at the time it was signed, we have a date, we have a living provider who legally signed the form. It does not need to be filled out and adjusted. Many people will adjust the pulse form if their doctor has died and they want to have a new doctor to call, but the doctor that signed the form is different than maybe their primary care provider. Many of my patients are dealing with the fact that I have told them I'm retiring. So I may be listed as the primary care provider, but the phone number on their form will still get the practice that I'm affiliated with St. Mark's Family Medicine. So death, retirement, I mean, it all is part of forms. I hope that answered the question, Rob.
Yep, thanks.
We also had another question, Cami. I think you touched on this briefly, but clarifying how the advanced care plan and pulse complement each other. It seems to make sense to just complete a pulse. Perhaps the advanced care plan is more of an education tool.
Yep. So the advanced care plan or advanced directive literally is for, it gives more than one person. It has, these are the two main people I want you to call. The first page of the 4-page form is the meat of the matter. Who do you want to make decisions? And in times when someone is sick, it becomes a nightmare for hospital medical people. Who is the right person to talk to? And I can give you a quick example. I was taking care of a couple, husband, wife, who they came down with COVID, very sick. They came in by ambulance. We were able to get their advanced directive from their primary care provider, since they're the ones that called the ambulance to their house to get them both sent, because they could tell that they were not doing well and no one was there with them. They were all alone. They showed up in the hospital. We didn't know who to talk to, but the wife was designated as the husband. The husband was non-communicative. The wife said, I only want you to talk to my grandson. She told us verbally. That was who, because she only listed her husband and we couldn't talk to him. So then we took the grandson and so we actually used him as the main spokesperson. And she had even said, he's the only one with a key to our apartment. Don't talk to any other family members. So in talking to him, he was heartbroken when his grandparents were so sick. And we were actually able to bring him in because his grandma did get transferred out, but his grandpa was eventually transitioned to hospice and sent to the same facility where his grandma was sent to recover. So, I mean, I tell you, COVID has been so challenging for the situations when we can't have people come to actually visit their loved ones as they are seriously ill. So there's a question that lists both PCP and an OBGYN or any other member as the main provider. I think you want to list who is the person you want them to call, who's the main person. Some women only have an OBGYN. Some OBGYNs feel they are the primary care provider because that's the only doctor this woman sees. But often OBGYNs sometimes do not feel comfortable with discussing these situations. I don't know very many OBGYNs who are filling out pulse forms with their patients. So I hope that addresses, but it's with whoever is your main doctor. And then I see another question. What do we mark on advanced directive for patients that are donating their entire body? Good. That's a great question. I actually had a patient tell me, he says, doc, I ain't got anybody. I'm donating my body so I know I'll be buried. So I said, well, have you filled out the forms? Because I knew this man to be illiterate. He didn't know how to read or write. He was from a different state and he was just kind of supported by friends, had no family in town. So I actually called to find out where he wanted to donate with the University of Utah Medical Center. And unfortunately, he weighed more than 300 pounds. And donating your body is a fine thing, but they actually have a weight limit. And I did not know that. So I was able to inform him. Unfortunately, when someone dies, when they don't have anyone, There is a way to bury, they usually cremate and bury in paupers' graves. It's kind of sad. It's very sad with folks that have no one there to speak for them. All right. So there's a question from Mark Dale saying, did I miss, what if a person does not have anyone in their life they want to be a proxy? This is a common problem for homeless folks, people who are transient, alcoholic, or they come through the hospital. They literally have no place to live and nobody to talk to represent them. This becomes very difficult if they go unconscious, because sometimes we do have to get a guardianship of what is the best decision to be made. If you can find out what this patient wants while they can make their own decisions, and when they go unconscious, the pulse form can last. If they did not want to have CPR, you can honor that from the patient's point of view, but contacting their loved ones and letting them know, it's pretty sad. So there's a comment from Andrew about that there's lots of criteria. It has to be met in order to donate a body. And that is very true. And in COVID, we've had very challenging times with that as well. Question from, does a person need an agent if they wish to have all their interventions performed? Actually, if you know you want everything done, you can actually tell that yourself. You don't need someone else to say it. It's nice for family members to know, because or friends. One of my good friends asked me to be her healthcare spokesperson in addition to one of her brothers, because she actually didn't feel comfortable with her older sister and an older brother, but she did feel comfortable with another brother, and then she wanted me. So I couldn't sign her form because I'm her healthcare proxy. I know what she wants. I've known her from kindergarten to 12th grade. We were in Brownies together. So we're good friends, and I was honored that she wanted me to be her healthcare proxy. But if I were her physician, I would have to say, I cannot be your proxy if I am among your healthcare team. Other questions? Did I get all the questions we needed? We're getting low on time here.
Amy, let me ask you one just to set up in case we've got a couple of minutes here. One, you've pointed out the utahaging.org website and the information from this conference and other conferences, including the conversation you just talked about orphaned adults who don't have somebody to turn to, can be found there. There were questions about comparing the POLST with the advanced directive. When is each appropriate? What are their purposes? There's some charts on there that you helped create, actually, that help explain those differences. You described one time for me a situation that when an individual was being persuaded to have a particular surgery done late in life that may not really have necessarily prolonged or enhanced the quality of life, but it certainly was a costly procedure. And you, as the primary care, were debating with this specialist about why would we be doing this for a patient. There are ethical decisions that get made, and ultimately what these conversations are all about is to make sure people understand the trade-offs and that their wishes. You want to talk a little bit about that, some of the ethical challenges that a provider confronts as they're trying to help people make the right decisions?
Yes, and I find that happens when someone comes into the hospital and needs an urgent surgery. For whatever reason, if they've had a broken hip or if they're having chest pain and they might need a cardiac bypass, but they have really expressed their wishes that if their heart stops, they are not breathing, they really do not want to be resuscitated. This is a challenge for medical providers in a hospital setting for the United States of America. I'm not too sure how it is in other countries, but our hospitals are measured. And if you have someone die in the OR, this is a bad mark on the hospital. So surgeons typically will not take someone to surgery who is not, they have to be full code while they are in the operating room, which actually goes against the ethical rights of that patient. If their heart stops and they are not breathing, we should honor those wishes, and the hospital shouldn't be punished for just because they happened to die during the surgery that was to help make their life more comfortable, whether it be a hip a pinning of a hip of someone who broke their hip suddenly, and yet they're at their end of the life. I think palliative care is palliative surgery, where we are approaching surgery that we know it's not going to save the person. They might still die. But unfortunately, sometimes patients are coerced. If you don't want me to do the surgery, just go home and die, which is what a specialist did say to one of my patients, which I was like, and she did get the surgery, and she said she signed a form that she would be full code for the next 32 days or whatever. And I said, well, the beauty of this is you can change your mind now that the surgery's done. And she became DNR during that hospitalization, but she didn't die in the operating room. She didn't even die in the next 32 days, but the specialist and I did have words about that decision. But Rob, I hope that elucidated the situation you were discussing.
Yeah, thanks.
How are we doing on time?
I think that brings us to the end of our time that we had for the Q&A. Yes, and Rob just shared that the state of Utah has a statutory hierarchy to select a healthcare agent for you. And maybe we can talk a little more about that guardianship and process with our panel discussion as well. So for now, we're going to switch gears a little bit, and we have a woman, Sherry Myers, that's going to be sharing with us a little bit of her experience about caregiving in the advanced care planning space. So Sherry and her husband, Craig, were married for 39 years before his passing on March 31st, 2013, Easter Sunday. They have 4 beautiful children, 3 sons and 1 daughter, 13 fun-loving grandchildren, and Sherry is very excited to be a great grandma this coming October. Sherry is currently a community liaison for Danville Support Services and loves to kayak. She lives in a beautiful cottage apartment by a creek. We are very excited to have Sherry share some of her personal experience today. So please, Sherry, go ahead and unmute yourself. And if we could move to the next slide. And go ahead, Sherry. I think you are still muted there.
Muted. There we go.
No.
Thank you, Adrienne, and good afternoon to everyone. And I would like to thank Margene Luke for asking me to share my story with you all. It was in 2003, after being in a hospital with blood clots, that my husband's pulmonary specialist decided to refer him to a hematologist and oncologist. And so Craig was tested for some solid cancerous tumors, but it all came back negative. And they did perform more and more tests, and they continually came back negative. So Craig was actually known as the mystery patient. And so in April of 2004, I still vividly remember that day when we got the call to come to Craig's doctor's office to discuss the results of his bone marrow biopsy and some of the other tests that were performed. And those results confirmed that Craig had multiple myeloma. And that's an uncurable blood cancer that has blood cancerous plasma cells that multiply. So this was just so devastating and life-changing for us and our children. Craig immediately started his chemo with that weekend and the hospital, and it went on for like about 3 months, hoping that those cancerous plasma cells would be killed enough so he could have a transplant, a bone marrow transplant in September. But it was disheartening that Craig's body did not respond to that chemo, and he had to go on to another chemo treatment for another 3 months. So that postponed his transplant until November of that year. Craig's transplant was done at UCSF Hospital, and it's University of California, San Francisco. We spent a month in that hospital during Craig's transplant recovery, and it was the most difficult time for me to see my husband and so sick and so much pain and hooked up to so many IVs. And it was to help his life-threatening state that his body was in. But I felt helpless. I felt like I wanted to do something to help his recovery. So Craig's bone marrow specialist had informed me that maybe I could give my platelets to my husband. The day that Craig received those platelets of mine was a really special day for the both of us. And I finally felt that I contributed to his recovery. We went home in 30 days, and it was kind of a life-changing situation, that how to cook and how to prep and what Craig could eat after his transplant. And I had to be his advocate also, because he was in isolation and he couldn't get sick even with a common cold. And I even had to tell his family that they couldn't come and visit him. And that was really hard. During his isolation period, which he had to do for several months, Craig only went to doctor's appointments, and that were in Chico and San Francisco. And that's the only thing he did. And of course, wearing his mask. The results of Craig's transplant was very sad and disappointing, because it was only successful at 10% of killing those cancer cells. And not only that, he came out of that partial remission in just a couple of months. So at the time that Craig came out of remission, the only thing that was available was a clinical trial called Revlimid, and Craig was willing to try it. It was grueling for me to drive down to the Bay Area every month and for weeks and months and work full time. But I knew how important it was to my husband to do this, not just for himself, but to help other multiple myeloma patients, and hoping that the FDA would approve it. And they did approve the Revlimid. And through my work at Danville, I was actually able to meet someone that had multiple myeloma and was in remission because of that Revlimid. So that was really touched my heart. And that was Craig's focus for doing those trials. Craig was part of the research at multiple myeloma at UCSF. We continued to travel down to the Bay Area, and it was a 3-hour one-way drive for us, but we were willing to make that sacrifice. And we did it almost at times every weekend for months at a time. We continued to travel to Craig's appointments twice a week. Twice a week for 9 years. That's really something. And plus going down back down to San Francisco monthly. This continued for 9 years while Craig battled this crazy cancer. Craig was dearly loved by all his medical team. Believe me, he had quite the amazing team. He never complained. He never whined and about what he was going through. His doctors would ask him, "How are you doing, Craig?" And he would say, "I'm fine, I'm good." And then they'd turn to me and go, "Okay, Sherry, how is Craig really doing?" During those 9 years, Craig was in and out of the hospital with infections and pneumonia, neurological, and other complications. But he continued to be the warrior with that fighting attitude to battle his cancer. In February 2013, Craig had completed another clinical trial. And the plan was for him to take a break for a couple months, and then he'd be put on a maintenance drug therapy. The saddest and the most devastating thing happened. Craig never got the chance to be put on that maintenance therapy drug. That March, Craig was at the infusion center having his IVIG infusion that he would have monthly, and he spiked a fever and had to go to the hospital. He was there for a couple of days and went home, but only for 24 hours. The fever came back, and back to the hospital he went. Craig developed an infection that attacked his brain, and eventually affecting his ability to walk and to speak. Those last 2 weeks in the hospital, he continued to decline to the point where the doctors talked to me about him being put on palliative care and comfort care, and that we would need to stop all medications and stop all his IVs. Our children flew out so they could be by my side while we met with the palliative care and comfort care team. I knew what my husband would want us to do. He did have his advance directive on file, but doing it was a different story. I needed my children there because they also knew, we talked many times about scenarios of what could happen to their dad. And so we decided to pull the IVs and stop all medications. And the next 5 days were so hard, lying next to my sweet husband in his hospital bed, watching his body slowly shut down. My husband passed away 9 years ago today, and it was an Easter Sunday with myself and our children at his side. The day that Craig and I were told that he had this terminal cancer, I told myself I was going to do everything in my power to be prepared for every aspect of the journey. But of course, there were unexpected visits to the hospital, other devastating diagnoses, and I realized there was no way I could be emotionally prepared for my loss. I was grateful that we had discussed and finalized his advance directive. We had an amazing support group from his medical team, our friends, family, especially our 4 children that did the best. I'm not going to lie, those 9 years were horrific and painful, with hopes and dreams broken. It was a roller coaster ride of emotions, never knowing what was going to come next, and especially knowing that he could pass at any time. It was hard, but I loved my husband and realized that I could have an impact on his life and be the best cheerleader for him. Caregivers do hard things, and they do it because they're compassionate about working and helping their clients or patients. They can be a part of that support team for that client's family. They can be advocates. Caregivers can have an impact on client and patient lives. Thank you for giving me this chance and this opportunity to share my story.
Wow, Sherry, thank you so very much. Really
Yes.
appreciate you taking the time to be with us today, having the courage and strength to share your journey with us. Your story really helps remind us about the important work we do and the impacts that are felt by people receiving care and their family and caregivers. And we just really appreciate you sharing this with us today. It's a beautiful thing that you've been able to be there, and we just really want to extend our gratitude and appreciation for you opening your heart to us and sharing with us today.
Thank you, Adrienne.
Absolutely. So we are going to segue over to our panel presentation. I'm going to hand the mic over to Rob.
Great. That was a virtual handoff of the mic, wasn't it? That was great. Sherry, thank you. Thank you so very much. It's such an emotional response when you hear someone's journey, and we deeply respect what that was for you, and hope that we all are taking away something that was dear to your heart. And so thank you for being vulnerable, and we welcome you to the panel conversation. I hope that you'll share some other insights with us. Joining our panel today, in addition to Sherry, is Andrew Lane, that you see his picture there. And he's had a couple of comments in the chat, who is a hospice provider, a licensed social worker, works for Intermountain Care. And then we also have Maria Cruz Gray, who works with the Hispanic ministry in the Catholic Diocese of Salt Lake, and brings an interesting perspective, not only for underserved populations, an ecclesiastical perspective, but also multicultural. And Senator Iwamoto, who is also an attorney, will join us. I think she's making a presentation right now to the YWCA. And that was a commitment that she had first, and she'll do everything she can to get here. And so we'll go ahead and proceed. And Dr. Collette, if you're still with us, I think you are, I may call on you as well until we hear from Janie. So
Service.
yeah, maybe just be available. That'd be terrific. So here's the first thing I would like, and you're welcome to put questions into the chat for the panel. and Adrian will help monitor that. But let me just start things off by asking the panel. We just are hopefully coming out of a 2-year pandemic period. And when I first heard about the pandemic and we realized what this might mean, I was talking to an epidemiologist who said that a lot of times these things take 3 years to actually cycle. And I thought that can't be. Of course, this is only 1 month into it. How could we go 3 years like that? And yet here we are, 2+ years now, and we're just sort of surfacing. This has had great impact on the way healthcare has been delivered, the way we interface with people. Sherry talked about the challenges that existed in the treatments with her husband, and trying to imagine layering that with COVID on top of it. So here's my question to the panel, starting with you, Andrew. What are the takeaways you've had from COVID in the way you've experienced individuals dealing with these end-of-life conversations and the choices made, impacted by this pandemic?
Thank you. Can everyone hear me? Hopefully, I think I unmuted myself. You think after 2 years, we know how to use Zoom so well. I thought a lot about COVID and kind of the pandemic, and I remember very vividly one weekend that we had at Intermountain Hospice, and we had probably about, it was probably 6 or 7 months into the pandemic, and we had, I would say, 15 to 20 patients that came into the emergency room over the weekend and then discharged back home on hospice. And that sent a panic through all of us, because it was like, oh my word, the hospitals are full. They're sending these people home to die. And it was really overwhelming. And part of my role on the hospice team is to talk about the advanced care planning. And I remember very vividly multiple families saying, we saw a spike in hospice numbers because people were going to the hospital, and there might be treatments that they could do, but they would have to be admitted to the hospital. And at that time, visitation was really limited. And so people would say, I want to come home. I would rather be home and with my family. And it was just so eye-opening, and people were willing to, a lot of people said, no interventions, please just keep me home, because that's what's most important to me, is to be home where I can be with my family.
Thank you, Andrew. Maria, could you comment on the same thing as what you experienced in your work with the individuals that you interface with, how they manage some of these challenging conversations during the last couple of years?
Well, thank you for your question. Everything was very difficult for us. The decision when somebody comes to us to tell us that they have a problem, especially with health, it is always difficult. But when the COVID arrived, it was like the whole world came down. We were very concerned because many of they were sick. Maybe people were sick. They don't speak the language. They didn't know where to go. They didn't even have medicals or the medicines. So it was very difficult to try to help. Our office is very busy usually. So when the COVID came, it was just like a war coming to our office with so many questions, because the language barrier was extreme. We needed to go and try to help them to find where the doctors, and we didn't have the manpower to do that. So it was very difficult to be able to help all of these wonderful people then came and trust us with their life, and we really then have a good situation how to help them. But the same people later on, when they recuperate of the shock, what was going on, start helping each other, the neighbors, their friends. It was wonderful to see the support of the families and people. Then as soon as they know something about it, they will get together and help people how to see, how to know what was going on and how they could have some care.
Maria, do you find, particularly amongst the immigrant population, a lot of distrust or concern about doing anything with the traditional systems we have in healthcare or these legal documents for fear or mistrust of policy or government?
Thank you. I want to tell you that it's a holy untrust. You know, it's not that they don't think the people are nice to them. It's just that they have a language barrier, cultural barrier. They are usually with their children. They came from another country, and they are very scared what is going on with them. Yes, so they don't trust anybody, not even themselves, when they are ill, because many of them don't have any knowledge in what is going on. And on top of all, on the lack of documents, and the difficult for their language. So yes, it's very difficult for the older people when something like that happened to them.
Thank you very much for that. I want to welcome Senator Janie Iwamoto, who has joined our panel, coming off of another presentation indicated. And Jenny will be right with you with a question in just a moment, but welcome to the panel.
Thank you.
Sherry, we had a question from Lee White asking if you would be willing to share a little bit about your experience with home health services during your decade-long ordeal.
Actually, when Craig was in the hospital for those last 2 weeks, we weren't sure if we were going to fly him back to UCSF, whether it would be worth having him airlifted there, or bring, talked about hospice, but he was in a condition that after all the doctors, including our doctor in San Francisco, talked, it was best that we do the palliative care, and hospice was never an option for him, or home care. No, we never got that far, we
That's
talked
that
about
point.
it.
Right.
But he got to the point where he wasn't even able to go home with hospice, that he passed away at the hospital.
Thank you, Sherry. So let me ask the entire panel, and we'll start with Senator Iwamoto on this particular one. But as we think about in our professional roles, what can we do as professionals and policymakers or influencers to improve the end-of-life options experience? And I would say this to Janie, if you had one wish for our legislature or policy that could change that would regarding end-of-life care for the state of Utah that should be adopted, what would you recommend?
So I guess for our legislature to recommend to them, I think
that might be a Sisyphean task. I realize that.
I know. Well, I think I'm looking at for the elder, what's important for our elderly and things. I'm just saying the wish for it's hard, for them to, I've had, when we started the Falls program, even though, I guess you have to look economically when you're talking to the legislature too, and how important it is that we look at these things, because like the baby boomers and everything. We're getting older and maybe personalize it to them. But I think one thing that has been really important, and maybe I'm going off on a different angle, but I think supporting the independence of our elderly is so important that they, you know, that helps all of us, you know, that keeping them out of long-term care if we can, and keeping them in their homes is so important. And I think, you know, our legislature can relate to that because we all have someone elderly there. But I think that, you know, we all have the experiences of that, and keeping them independent, because we know how much the care will cost, and cost to the lives of our loved ones, but also to the state. So that's hard. I can tell you a lot of the bad things that the legislature has done in the last year or two, but and a lot of the good that's been done. But I think the end of care and life choices, you know, we did the Post agreement, and that was no easy feat, you know, because of how they are. But I think that it advanced directives, and I just I think having those choices available and focusing on the independence and how important it is for us to support that effort. And I don't know if that's a good answer or not, but that's the only thing I can think on that part.
No, that helps a great deal. And I know that the legislature did take some action to help with, I think, at least Medicaid eligible folks, to help with some of the work with unpaid caregivers, which is an issue obviously addressed in this future. And this was a big part of Sherry's life as she described it for a period.
I know the caregiver issue, we talked about doing that this year, but I think that is a huge, huge issue that we need to think about, that was highlighted during COVID too, and how much more responsibility it left on caregivers. And I've seen how hard that has been, you know, and in my age group too, balancing work and being a caregiver. And we need to really support our caregivers. And I think that's something that's really, really important.
Thank you for that. Andrea, let's turn to you just for a few thoughts on that arena, in terms as a professional, the work you do, the counseling you do. How can you make this experience of having end-of-life conversations with folks you counsel with a better experience? How do you get buy-in from families on this?
You know, I think that's the million-dollar question, right? To get people to, this is such a taboo subject. I think what's really helped me is, so I've been doing hospice for a few years now, and my own father was actually on hospice in October, and he passed away in October. So for me to be on the other end of the spectrum, so to speak, and to be able to, I mean, I will never, for, you know, years, I've had multiple daily conversations with people about the Post and Advanced Directive, and I will never forget when the hospice nurse was admitting my father and went over the question. So my dad was 65, and went over the question of, if, you know, Doug, if you were to stop breathing and your heart was to stop beating, would you want CPR? And my dad immediately looked at my mom and said, yes, of course I would want CPR. I would want to be revived. And that was really eye-opening to me, because I thought, you know, trying to understand where people are at in the process. And sometimes it's so hard to wrap your head around the thought of being mortal, and this is the end of life that's coming. And so I think that the best thing to do, or the best thing that I found, is when I'm working with families, specifically different cultures and things, is just to build that relationship with them, and let them know that I am an advocate for them, and I am truly there to walk the journey with them and to meet them where they are at. And if they're at the end where my dad was, that's okay. I will meet you there, and we'll kind of work through this. But I think that's the hardest part is, and with hospice and end of life, as anyone has been a caregiver experience, it's just, you know, it's ups and downs and changes often moment to moment, and that can be so emotionally taxing. And so I think having those conversations. I always try to have the patient, if the patient is able, I would much rather have the patient fill out the pulse with me or the advance directive so that there is no question what the patient wants, because when that time comes, families often become desperate and emotions take over.
Yeah, thank you, Andrew, for that. We often sort of use the phrase that if you don't make decisions, then decisions will be made for you. And then you have systems acting on people that often result in events or interventions that would not be desired or necessarily afforded. But I appreciate your insight with that. I was just reflecting back on something that Dr. Collette had talked about a little bit earlier, in that she was not able to provide a patient the answers they wanted to hear relative to their beliefs in life. And so they wanted to find another doctor that would sort of support, the fact that, well, we don't believe we're going to die. So we're going to have to talk to somebody else who will support that point of view. I'm just asking, Maria, do you find occasionally a challenge of helping individuals with their faith and their strong beliefs, particular points of view, and reconciling the reality of planning for and dealing with subjects that aren't necessarily comfortable for them?
Of course, we find all kind of situations, but we feel that the elders have a lot of wisdom, and they have. We need to respect their wishes and to be compassionate with them. Some of the death issues are kind of taboo for some of the people, but not for the older people. Mostly it's their own children that make the situation harder when they treat the parents like they were little children again. And I believe that the most important thing we can do is information. Of course, from the ecclesiastical way, we find out the difference between the people they have the strong faith. It's easy for them to understand that there is a death and the death is not the end. But sometimes, even though they know that, that's what we know it because they teach us that. And that's why I think the older people need a lot of respect. They need a lot of information about that. They need to know when they go to the special places that there are special forms that they can fill up in their own decisions, but make them with a lot of respect and compassion, like they are very important people. In our culture, the grandparents are the max authority in our house. They are very important. So respect is very important, but also they need to know that perhaps they have in a different place and they need to be informed of the regulations. But I repeat, a strong faith make the whole thing very important. And so I believe the youth have very good regulations about the elders. They can always be improved, but especially they inform them, then there are other choices, and that choices, they can be their own, and make them feel they are important enough, then whatever decisions make, they are going to be okay.
Thank you for that. It's incredible. Thank you. Sherry, put it on your other hat with your work at Danville. And I'm drawing from personal experience. How do you work to make these conversations, how do you facilitate them and make them comfortable for folks to discuss?
Well, as a private in-home care company, we get calls when families are in the crisis of the situation of ending life. And that's probably the hardest and the worst time to make final decisions and not have those advance directives and have the family all on the same page with the decisions that are going to happen, because we do see families that their relationships are broken because they're not all on the same page of what their loved one might want for them to do. When we go out and sign up clients, by the state law of Utah, we have to have the PULSE form in our packet. And we can only encourage them to fill that form out and hope that we see it on the refrigerator. Our caregivers get to see that and know what the details of that, as far as what they need to call the hospital, or what 911 or whatever, or even if they're on hospice. We know that our caregivers know to call hospice and have them know what's, be their advocate for hospice for their client. I think we need just to educate them more and give them, be a resource for them, and just be an advocate for them. And we've been told that, we've been thanked for being their advocates. And it's a hard position to be in, but it's very rewarding to be able to help families get through their hard time and be more aware of what they need to do.
Thank you very much for that. I appreciate it. No, it's great. Nope. Just a quick response to a question about who can we reach out to talk about the issue of unpaid caregivers. And so, as Senator Iwamoto said, that's an issue that has just started to be addressed at the legislature. It does have financial implications. Lots to be done there. Just an FYI for the group, some of you are aware and at some point will be informed, there is a family care giving collaborative that is drafting a state caregiving plan, and has already a couple of drafts in place, and we'll be sharing this with larger reach of stakeholders to make sure that we've got a good collective plan for the state that addresses a lot of these issues, economic as well as, economic is a huge part of it, but all of the things that impact family caregivers, and with a focus on the fact that they are unpaid and they contribute a great deal to the economy of the state. And so kind of watch for that. I would also suggest that for folks who want to know what eligibility is out there and available for caregivers, they can go to the caregiver specialists at the Division of Aging Adult Services, as well as the area agencies on aging have information about care support, respite, and so on. And all of those services can be tracked down through the website, as well as going directly to those agencies. So there's a lot of work to be done in that arena. My final question, starting with Senator Iwamoto, deals with, Jenny, we've talked and you've shared a great deal about your wonderful family relationships and how part of your decision to step away from public policy making is to be able to spend time and address some of the issues that are imminent in your own family with mother and so on. Talk a little bit about what your wishes would be for your loved ones in understanding their choices as they make their end of life decisions.
Okay, thank you. So there's a lot of wish lists I have too for the legislature. And I did, when I got in, it was really important to me. We did get, I did work on money for a long-term care support, like array services that we're going to study. And that was supported by AARP and also the Disability Law Center. It's been at my heart looking at long-term care, reforming that. And I think one thing I just want to say in general, and thank you to you, Robert, because we've been working on a lot of things together and I've learned so much from you, and we got a falls group together to study that. These are like huge issues that to do. And we've gone through some experiences in the legislature together, but I wanted to just say too, elders are so important. And I think the importance of our elderly community was really highlighted in COVID because you know, with the Native Americans and how many elderly they lost, and keeping the stories of our past together and that connectivity to our elders, you know, and that was something important to me too when we did the Mill Creek Community Center when I was on the county council, to have the aging service with rec center and library and the youth together. But I think what's really important for me is, yes, it was a hard decision, but I said a simple one, because when I thought of my mother, and she's very independent still, and she goes, don't tell people I'm almost 33. I'm really 93. I'm 92 still, because there was some interview I did. But I think the most important thing is supporting the independence. You know, their independence is so important. And if no matter where they are, even if they're in a long-term care, the connectivity that we saw without having laptops and knowledge of that, they couldn't go to senior centers, they couldn't go to the library. And I think that's so important to keep those communications and to talk about things early on. Just recently, I guess I shouldn't say in public, but but I know for my mother, it was really important to know where things will be going. And my father, before he passed, it was just a web of for me, even just getting through, because he had VA benefits. And I just saw the stress on our elderly and their families, just knowing how to do things, to go, you know, what resources available. And there is a wealth of resources available, but it's really hard, especially if you're at the end of life, to make those decisions. So I think the most important thing that I found is supporting the independence. And also the advance directive, even though I don't want to even talk about like what money there is or anything, I think it should be spent while she's alive, you know, and enjoy her life and do that. But I know how important the independence is, and making sure that that advance directive and how they want to end their life, because they want, you know, if you want to be kept alive and have extraordinary things to keep you alive, or those are hard topics to do. And being a lawyer too, I was appalled when I look at wills and trust and think about, wow, these are all families suing each other, you know. And I thought, this is just terrible, but it really doesn't have to be. It's just that it's hard to go through this end of life things with your parents and your loved ones. And I can't imagine life without my mom, you know, and all of her friends are going. But I think really talking it, we had a little talk this last week, just she had to get things off her mind, and it made her feel a lot better. So I just think end of life and getting those directives done is really important. If we can keep them in the homes, do everything we can to keep them in their homes, having services at home, caregiving, training, everything. And then if not, making those long-term places. That's one thing I never got to do, but I really think there's things we need to do. I've heard lots of horror stories, but I just making them comfortable and connected as much as they can, whether they have families or not, and telehealth or whatever. And just thank you to all of you for all that you do, because I know that all of you do and have expertise that I don't have. I have more of a practical expertise and things that I feel need to be changed. But thank you so much.
Thank you, Senator. We appreciate that and all your service. So to conclude, I'd like to just offer Sherry, Andrew, and Maria in that order an opportunity for a last comment or two of what might be on your mind to share with the group before we wrap the panel. Sherry?
Thanks. I just want people to know that I love my job as community liaison at Danville Services. I've been with them for 5 years. They hired me as a caregiver first because of my experience of taking care of my husband. And then I had the opportunity to come into the office and be a care coordinator, and being able to work with the clients and the caregivers together was amazing. And then it's almost been a year that I've been now the community liaison. And I just feel like I've been able to help people. I always wanted to be a nurse growing up, but I got married instead. But I feel like I'm making a difference in families' lives because I can feel their pain. I can relate to their loss and that heartache. and that grieving process is so hard. I lost my dad in January. And so we're helping with my mom now. And Northern California doesn't have the beautiful places here and the options that we have here. So it's been a struggle. But I just want you to know that I can be an advocate. I can be a resource to our clients. I can just be there for them and know that we're there to help them.
Thank you, Sherry. And again, thank you so much for your story today.
Yeah.
Andrew.
Thank you. Yeah, I just want to echo what Janie was saying about the independence and the respect for the elderly. I think as I've thought about this panel and just different things, and of course my own experiences with my family, I think that it's important that as we're having these decisions and the importance of the advanced care planning, because like Sherry said, at 3 a.m. is not the time, or, when there's in crisis calling for help, that's not the time to make the decisions. And I think just educating and continuing to respect those that are in this and have that empathy, like Sherry was saying, because it's such a difficult decision, but, allowing and being an advocate. And sometimes I feel that the elderly kind of get pushed away. And so I think it's important that we do all that we can to support them.
Thank you so much, Andrew, for your participation today. Maria, final word.
Thank you. There is so much that I would like to say other than thank you so much, because you are teaching me right now that many other possibilities, but most than anything, I would like to know, you already know about that, the elders need the respect, and they need to know that they are part of their community. Don't just put them in a chair and forget them. Whatever they need, if they need a special care, just talk to them, be kind, compassionate, let them know whatever the regulations are. Sure, they need to be independent thinkers. They are smart, and they bring a lot of wisdom to the society. But also, when they have their worries, let them know then that's part of life. Then they need to be part of that community. Visit them, talk to them, make them feel that they are very important. Life is very important from the birth till the death. And there is much more for them to wait. Make them feel then the life is worth to live, and every experience is worth it. Thank you.
Thank you, Maria, and thank you for your contributions and participation today. Also want to thank all of the panelists and Dr. Cami Collette for her time and presentation and agility, great expertise.